Hi everyone, this is lecture 29 on renal physiology, and here we're going to apply many of the principles which we learned in lecture 28 in the introduction to the kidney. And we'll try to go carefully and slow because the kidney can get a little confusing. So in this lecture we're talking about glomerular filtration, tubular reabsorption, and tubular secretion. These are the three major processes that are occurring throughout the nephron, or through the nephron. Okay? We'll talk about the factors that affect the glomerular filtration rate, and those forces that support and oppose filtration in blood kidneys. And finally, we try to understand the nephron and the collecting system and its role in reabsorption and secretion. So remember, there are three basic processes that are occurring in renal physiology. These are filtration, reabsorption, and secretion. And these are occurring in the nephrons, the functional units of the kidney. Glomerular filtration is when the blood is filtered as it passes through the glomerular capillaries. So in this picture here, we see the nephron showing the renal corpuscle right here circled, and if you notice a little purple arrow here, this indicates that this is the location of where filtration occurs. So filtration only occurs in the renal corpuscle. Tubular reabsorption is when substances are reclaimed, or things that passed into the filtrate are taken back into the peritubular capillaries. This occurs mostly in the proximal tubules and nephrons. However, there is some controlled reabsorption in the distal tubules and collecting ducts. Now, if we go back to our same figure here, now we've circled all the green arrows. And all the green arrows are where tubular reabsorption occurs. So tubular reabsorption occurs or may occur throughout the nephron and collecting ducts. The third process important for renal physiology is tubular secretion. This is where the substance moves from the peritubular capillaries back into the filtrate. And if it stays there, then it'll be excreted. And this occurs all along the tubules, although some with more in one area than the other. And so in the red arrows here are showing where secretion occurs. So here we have secretion in the proximal tubule and the distal tubule and in the collecting ducts. So let's begin now. A little more detailed look at each of these processes. Glomerular filtration. You've heard this term before in SCB 203 in the first lab when you did filtration. When you put a semi-permeable membrane, which was a filter in a funnel, and we passed over three materials. One was the activated carbon. We put on the sodium chloride and the starch solutions. And you did chemical tests to determine which passed through or not. And you determined that sodium chloride was the only one that passed through, whereas the starch and the activated carbon stayed on top. And the main reason was because those molecules that stayed on top are much larger than the sodium chloride. And so what you did was filtration. Filtration is the separation of molecules by size. And essentially that's what the kidney does in the renal corpuscle. Okay? So the glomerular filtration, the renal corpuscle allows the filtrate to pass, leaving behind larger substances. Big stuff, the small stuff can pass through, the big stuff stays behind. Now, what makes the glomerular filtration a little more complicated and more refined is that there are three filtration membranes, three layers. So it's like there's three coffee filters. These include the capillary endothelial cells, the basal lamina, and the podocytes. Okay, so in this table here, I've summarized the filtration membrane. We have capillary endothelial cells. These prevent formed elements from leaving the capillaries, so there should be no blood in your urine. The basal lamina prevents most proteins from entering the capsular space. The charges on the protein fibers in the basal lamina repel smaller proteins. And the podocytes have these foot processes called pedicels that form the filtration slits that permit substances smaller than 67 nanometers. So these are the 3 layers of the filtration membrane. Okay, and so we see here the fenestrations of the endothelial cells here, much smaller than the blood cells. Okay, so what does pass through? Well, it's better to say what does not pass through. So most formed elements, the formed elements of the blood and proteins do not pass through. What passes through are water, small dissolved solutes, electrolytes, very small proteins, amino acids, and nitrogenous wastes, which include urea, ammonium, uric acid, and creatinine. Now, an important concept is what's called the filtration fraction. This is the percent plasma passing through the filtration membrane to become filtrate. And the filtration fraction in a normal kidney is about 20%. And it's just due to the large surface area of the glomerular capillaries. Another important concept is the glomerular filtration rate, the GFR. It's the amount of filtrate formed by both kidneys in 1 minute. The normal glomerular filtration rate is 125 milliliters per minute. This accounts for about 180 liters of filtrate per day. So this is an important concept, because if it wasn't for our nephrons that's going to modify this filtrate, we'd be going to the bathroom quite a bit during the day. I'm pretty happy that I don't have to urinate 180 liters. But because our wonderful nephrons, which absorbs much of the water, it's much less. The high filtration rate is due to the pressure gradient pushing water and solids through the filtration membrane. So the kidneys are under a high pressure to allow for this high glomerular filtration rate. And it's due to these filtration pressures. And if you recall the pressures of a capillary back in the SCB 203, the names of these pressures are the same in the kidney, are fairly similar at least. And these include hydrostatic and colloid osmotic pressures. Okay? The main one is the glomerular hydrostatic pressure. So this is the force of fluid on the wall of a container. So if you consider the renal corpuscle a container, the blood that's entering the glomerulus is under high pressure because it's coming right from the renal artery. And it's equal to blood pressure, about 50 millimeters per mercury. And this pressure pushes water out of the capillary into the interstitial space. Okay, so here's our renal corpuscle, and here's the afferent arteriole that's entering blood into the glomerulus, and the efferent arteriole leaving it. The glomerular hydrostatic pressure is 50 milliliters per mercury, and with a big arrow to the right, meaning showing that it's favoring filtration. Another important pressure is the glomerular colloid osmotic pressure, and this is due to the pressure created by proteins in the plasma. And the proteins in the plasma are going to try to pull water back by osmosis. And this is about 30 millimeters per mercury. So the osmotic gradient pulls water into the capillaries by osmosis and opposes filtration. So the proteins in the plasma are going to try to pull water back. So this is going to be antagonize or go against the glomerular hydrostatic pressure. So that's why the arrow is going to the left. Well, it's a smaller arrow because 30 is smaller than 50. So far, our glomerular hydrostatic pressure is still winning. The last one is the capsular hydrostatic pressure. And this is the pressure of the filtrate inside the capsular space. The fluid builds up inside the capsular space, and this is going to oppose filtration, and it's about 10 millimeters per mercury. So here's the capsular space right here, and as the fluid builds up, it's going to oppose the glomerular hydrostatic pressure. Normally this is only 10 millimeters per mercury, and since it's fighting against hydrostatic pressure, it's pointing to the left. Okay, and 50 is bigger than 30 plus 10, so the net filtration pressure is 10 millimeters per mercury to the right. And so this is what we want. We want filtration in our nephrons. Okay, if it's to the left, then we have major renal problems. So here is a tally of all our pressures. The glomerular hydrostatic pressure is 50 millimeters per mercury. The glomerular colloid osmotic pressure is 30 millimeters per mercury, and the capsular hydrostatic pressure is 10 millimeters per mercury. And theoretically, we determine what would happen. We actually have an equation called the net filtration pressure, the NFP. It's equal to the glomerular hydrostatic pressure minus the sum of the glomerular colloid osmotic pressure plus the capsular hydrostatic pressure. And so we input the numbers. What we get is what we calculated before. 50 minus 40 is 10 millimeters per mercury. It's a positive number, and so that positive number reflects that we are having filtration occurring. So the net filtration pressure is about 10 millimeters per mercury. Another factor affecting the glomerular filtration rate is arteriolar diameter. Okay, because the pressure gradient determines how much filtration occurs. And arterial diameter, as you learn from SCB 203, can influence the velocity and pressure of the blood inside the vessel. Smaller gradients produce minimal filtration, while larger gradients result in more filtration. Okay, that's pretty kind of logical. And this can occur through constriction or dilation of the afferent or efferent arterioles that changes the GFR. Okay, so the next concept is fairly straightforward. However, you got to think about it, and it will make sense if you think about it. So what happens if we have afferent arterial constriction? So this is the blood vessel that's entering the glomerulus. If we constrict here, what happens, we're not letting blood into the glomerulus. This will decrease the glomerular hydrostatic pressure and glomerular filtration rate. I think you can envision this. Okay, it's like sort of like squeezing a garden hose and not enough water comes out. Now, what if we have efferent arteriolar constriction? We constrict it on the outlet. Well, what happens is clogs the drain, builds up pressure in the glomerulus, and this will increase glomerular hydrostatic pressure and increase glomerular filtration pressure. Okay. In our third possibility, what if we have vasodilation of the afferent arteriole? What happens, we make this wider so more blood can enter. This is going to increase the pressure in the glomerulus, and it will increase the glomerular hydrostatic pressure and increase the glomerular filtration rate. Finally, our last possibility is vasodilation of the efferent arteriole. If we increase the outlet, well, that decreases the pressure in the glomerulus, and this is going to decrease glomerular hydrostatic pressure and decrease glomerular filtration rate. So I think these are pretty straightforward. You just got to ask a little bit about it. And so I've summarized it in this table here for under each possibility. And your body will make use of these changes to have the effect on the glomerular filtration rate. So we're going to come back to these in our discussion of the kidney. Now, what other factors affect the glomerular filtration rate? Okay, well, there's different factors, and these may originate within or external to the kidney. And if they're within the kidney, we call it autoregulation, because it doesn't require any external control. If it's external, it's usually controlled by neural or hormonal factors. Okay. Now, autoregulation of the glomerular filtration rate is due to the local responses that we just said. And it involves two different processes. One is called the myogenic mechanism. From this name, you can get an idea as to smooth muscle. And tubuloglomerular feedback. Okay, let's look at the myogenic mechanism first. This involves vasoconstriction of the blood vessels following stretch of a smooth muscle. Okay, so if you stretch a smooth muscle, in response, it will constrict. Okay, so what happens is an increase in blood pressure stretches the afferent arteriole to increase the glomerular filtration rate. In response, it results in vasoconstriction of the afferent arteriole to decrease blood flow, to decrease glomerular hydrostatic pressure and glomerular filtration rate. So it's like an automatic kind of resetting of the mechanism to maintain the GFR at a homeostatic level. Likewise, if there's a decrease in blood pressure, which reduces the afferent arteriole stretching, there's a decrease in GFR, making smooth muscles relax. Vasodilation of arteriole increases blood flow, that will and AHP and GFR increase back to normal levels. So here we're making use of our applications of the afferent arteriole. Okay, so I've summarized this in this little table here. We have the change in blood pressure, which it may increase or decrease, and we have stretching of the afferent arteriole, okay, which increases if there is a change in blood pressure, and decreases if there's a decrease in blood pressure. The initial effect on the GFR is going to be correspondingly increase if there's increased stretching, or decrease if there's decreased stretching. But finally, the autoregulatory myogenic mechanism will maintain homeostatic mechanisms because it will decrease GIHP and GFR from the initial increase, or decrease or increase if there's a decrease. So this is part of the myogenic mechanism of autoregulation of the glomerular hydrostatic pressure and glomerular filtration rate to ensure that the homeostatic mechanisms stay in normal levels. Okay. Another type of autoregulation is called Tubuloglomerular Feedback. And this has to do with the sodium chloride concentration in the filtrate. Okay. Now you think about this. As the glomerular filtration increases, the volume of the filtrate will also increase in the renal tubule. As a result, there will be more sodium chloride absorbed by the macula densa. Remember, these are the specialized cells of the distal convoluted tubule as it approaches the afferent and efferent arteriole. Well, the macula densa releases chemicals constricting the afferent arteriole. Okay, so here's a picture showing the macula densa here. It's associated very close to the juxtaglomerular cells, which are modified smooth muscles that are in between the afferent and efferent arteriole. Now, the macula densa signals juxtaglomerular cells to decrease renin secretion, which decreases angiotensin II, resulting in dilation of the efferent arteriole. As a result, the glomerular filtration rate goes back to normal. A decrease in glomerular filtration rate will then have the opposite effect. So it's a type of negative feedback. Okay, so here's the juxtaglomerular cells near the macula densa that's going to influence the arterioles. Okay, and so here I summarize tubuloglomerular feedback. So there's an increase in glomerular filtrate rate. There'll be an increase in filtrate. There'll be an increase in sodium chloride detected by the macula densa. This is called constriction of the afferent arteriole, which will decrease renin from the juxtaglomerular cells, decrease angiotensin II, and decrease glomerular filtration rate. And the exact opposite occurs if there's a decrease in GFR. So this is how the macula densa and the juxtaglomerular apparatus will influence glomerular filtration rate. So this is an important concept. Now, what about the hormonal effects of GFR? So these are some of the external factors. And two major hormones are angiotensin II and natriuretic peptides. Okay? So the renin angiotensin aldosterone system is an important hormonal control that maintains systemic blood pressure. You should have learned about this in SCB 203. Now, one of the additional effects of angiotensin II is to also preserve glomerular filtration rate. Okay, angiotensin II is triggered by several factors: sympathetic stimulation, low glomerular hydrostatic pressure, and also macula densa stimulation. So these three factors will increase angiotensin II levels. Okay, so if systemic blood pressure decreases, this causes a decrease in the glomerular filtration rate. Now, as a result, angiotensin II is secreted, and this is one of my favorite homeostatic mechanisms because it involves so many organ systems. Because the liver produces the inactive angiotensinogen into the blood, the macula densa produces, or the juxtaglomerular cells produces renin, the enzyme which converts angiotensin to angiotensin 1. The lungs produce angiotensin converting enzyme, which will convert angiotensin 1 to the active angiotensin 2. So, because this is a great homeostatic mechanism process because it involves the cardiovascular system, the respiratory system, the liver, as well as the urinary system for a common goal of the human body. Now, we said in our discussion of the kidney, angiotensin II will promote vasoconstriction of the efferent arterioles. And this will increase GFR. In addition, angiotensin II will promote vasoconstriction of the systemic blood vessels, promote reabsorption of sodium chloride from the proximal tubules, and water will follow osmotically. It will promote aldosterone release, increasing sodium water absorption, and will stimulate the third cistern of hypothalamus, which may increase in fluid intake. And all these will collectively increase systemic blood pressure. And as a side product, it will also increase GFR. Atrial natriuretic factor, ANP, is produced by atrial cells from an increase in atrial volume. So it's one of the few effectors that will decrease blood volume and blood pressure. So atrial natriuretic peptide will decrease blood volume and pressure to reduce the work of the heart. It does this by dilating the afferent arteriole and constrict the efferent arteriole to increase the glomerular filtration rate. So here's a summary of the control of the glomerular filtration rate of everything we've talked about so far. We have autoregulation, we have hormonal mechanisms, and we have neural mechanisms. In the autoregulation, we have the myogenic mechanism as Tubuloglomerular Feedback. And for the hormonal, we have the renin angiotensin aldosterone system and atrial natriuretic peptide. And of course, the neural mechanism is just the sympathetic nervous system, which I didn't say too much about because we covered it quite a bit in previous lectures. Now let's begin our discussion of tubular reabsorption and secretion, which occurs in the beyond the renal corpuscle. And many of these you might have heard already in SCB 203. For example, it involves paracellular and transcellular transport, as well as carrier-mediated transport for reabsorption and secretion. Okay, so what happens in tubular reabsorption? Substance moves from the filtrate across or between tubule cells into the interstitial fluid, across or between endothelial cells of the peritubular capillaries. Okay, and then now it's in the blood. In tubular secretion, the substance moves in the opposite direction. You just move it. The arrows the other way, and it goes back in the filtrate. Okay. So here is here's showing a proximal tubule, the tubule lumen, and the interstitial fluid, and the peritubular capillary. And so it has to cross through all these membranes for reabsorption from the tubule to the blood, and for secretion, it's going to go from the blood back over into the tubule. Okay. It's important to remember the concepts of reabsorption and secretion. Okay. Now there are two different routes of transport across the epithelia. These are paracellular and transcellular. Okay. In the paracellular route, substances pass between the adjacent tubule cells. Okay. And even though they may have tight junctions, these may have leaky tight junctions to allow small ions and water to move past between them. And this is especially so in the proximal tubule. So you can see in the paracellular transport, substances can squeeze between the cells. In the transcellular route, substances such as glucose and amino acids move through tubule cells. So they cross the apical membrane through the cytosol and past the basal membrane. Okay, so in transcellular, they go straight through the cell. But in the transcellular route, it often requires carrier-mediated transport. Okay, there are three different types that you learned and we mentioned several times during the semester. There's facilitated diffusion, primary active transport, and secondary active transport. Okay, so we won't go any more detail than that because we know that already. An important concept, though, which we didn't talk about before, is the transport maximum. Okay, I might have mentioned that if you took me in 203, that many of these carriers saturate. Okay, and these carrier proteins have a limited number of sites to transport substances. It can only transport so much at a given time. So once the sites become filled, the carrier proteins are saturated. Okay, if they're saturated, they reach their transport maximum, or TM. It's for every substance has their own unique transport maximum. For example, glucose has a transport maximum of 260 milligrams per milliliter. Okay, beyond this concentration, it's not going to be able to transport anymore, and maybe you might have glucose in your urine then. How about reabsorption in the proximal tubule? Reabsorption of the proximal tubule includes most electrolytes, nearly all glucose, amino acids, and other organic substances, such as lactic acid, water, soluble vitamins, bicarbonate, and of course, a majority of water is reabsorbed in the proximal tubule. So the proximal tubule is a pretty active area of the nephron. How about sodium reabsorption? Sodium reabsorption occurs mostly by sodium leak channels. Carrier proteins for sodium by facilitated diffusion, sodium hydrogen ion antiporters, for example, and sodium symporters, such as for glucose, as we learned in the digestive system. How about the reabsorption of other organic solids and ions? Okay, so the first half of the proximal tubule, they have sodium-potassium pumps and sodium-glucose symporters. Okay, the symporters uses the sodium gradient to move both glucose and sodium to infiltrate into tubule cells that are driven by the sodium-potassium pumps. So here in this diagram, we see the sodium-potassium pumps maintaining the concentration gradient of sodium and potassium, and that allows the sodium to move in through secondary active transport with bringing in glucose with it. Then glucose can lead through facilitated transport. How about bicarbonate reabsorption? Now, bicarbonate is important because it acts as a buffer to help maintain the blood pH of around 7.3 to 7.4. Okay. And so bicarbonate is going to be important for reabsorption. So blood carbon dioxide reacts with water to produce carbonic acid, which you learned in SCB 203 in the respiratory system. And it's catalyzed by the carbonic anhydrase. So carbonic acid dissociates into bicarbonate and hydrogen ions. And notice the arrows are double-headed because the reactions go both ways. And carbonic anhydrase will catalyze this reaction both ways. So this is one of the exceptions where we said that an enzyme is very specific. Here it can do both reactions. So this is an important reaction. So here we see that carbon dioxide reacts with water catalyzed by carbonic anhydrase to form carbonic acid. Okay, the bicarbonate is then pumped out by facilitated transport into the blood. The hydrogen ions are then pumped back out using the sodium hydrogen antiporter. Okay, and the hydrogen then can react with bicarbonate in the filtrate to form carbonic acid that's then converted back into water and carbon dioxide to continue to drive the formation of bicarbonate. So this is how bicarbonate is kind of recycled. We have what's called an obligatory water reabsorption, meaning that there's a certain amount of water that's always going to be reabsorbed, no matter what. And aquaporin channels are the ones that promote reabsorption in the proximal tubule. Okay, and what happens is the movement of water concentrates the solids to favor their diffusion. So it's kind of a cyclical manner because as the water is absorbed, it concentrates these solids, which then can have a concentration gradient for their diffusion. Okay, so here's some examples of what I mean here. So here we have the aquaporin channels that will allow water to pass out into the interstitial fluid into the blood. Okay, so we have aquaporin channels here in the apical membrane. We have it in the basal membrane that can then diffuse directly into the peritubular capillary. And as the water moves passively, this will concentrate the solute particles. And then as a result, this produces a concentration gradient for the diffusion of the solute particles themselves. And then they get into the capillary as well. Now let's look at the other way, the other direction, secretion in the proximal tubule. Okay. Secretion in the proximal tubule, such as hydrogen ions are secreted in the proximal tubules. Other things include ammonium, creatine, and a small amount of urea are also secreted. And even drugs, penicillin and morphine, are also secreted. Okay. And so so whenever you take medication, they have to take into account the half-life, because you may excrete the drugs, which will decrease the concentration in your body. Okay. How about reabsorption in the proximal tubule? About 60 to 70% of the electrolytes and water are reabsorbed, and most organic solids are reabsorbed. Now let's move to the nephron loops. About 20% of water, 1/4 of sodium chloride, and a significant amount of other ions. Water reabsorption is proportional to solute reabsorption in the proximal tubule. Okay, both filtrate and interstitial fluid are about 300 milliosmoles, and so the filtrate osmolarity changes in the nephron loop due to different permeabilities in ascending and descending limbs. So in the loop, it's going to be slightly different than we saw in the proximal tubule because of the different permeabilities. In the thin descending limb, it's freely permeable toward water. However, the thick ascending limb is impermeable to water. The thin descending limb is less permeable to sodium chloride. The thick ascending limb transports sodium chloride into tubule cells with these sodium potassium chloride symporters. In the thin descending limb, water moves out by osmosis, but few solids follow. Okay, because of this less permeability to sodium chloride. In the thick ascending limb, the filtrate is less concentrated as ions are pumped into the interstitial fluid. Okay. Now, remember I mentioned that the thick ascending limb is thick because it has more mitochondria to make ATP for these primary active pumps to work. About 85% of water and 90% of sodium is reabsorbed before the distal tubule. Okay. The filtrate flow decreases from 120 milliliters per minute in the early proximal tubule to about 20 mils per minute. So it goes much slower for the active reabsorption to occur. Now, at this point in the nephron loops, if excretion occurred now, we'd still be producing 29 liters of urine, which is kind of a lot. Okay, it's a lot better than 180, but 29 is still a lot. So fortunately, we have the rest of the nephron to conserve the water. So now let's look at the reabsorption and secretion in the distal tubule and collecting system. Okay. In the early distal tubule is similar with the ascending limb of the nephron loop. Okay. Late distal tubule is similar with the chordal collecting duct, and the medullary collecting system is much different from the previous one. Okay. So look at the hormone regulation of the distal tubule and chordal collecting duct. It maintains the balance of water, electrolyte, and acid-base. So these are important homeostatic mechanisms. Okay. Remember we mentioned about facultative water reabsorption, and this is based on the body's needs. It involves aldosterone, ADH, and an natriuretic peptide. So the effect of aldosterone. This will increase reabsorption of sodium and secretion of potassium by increasing the number of sodium-potassium pumps. Aldosterone will also increase reabsorption of water and chloride, but only if antidiuretic hormone is present. Okay. Aldosterone will also increase secretion of hydrogen ions and of the late distal tubule and collecting duct. This does this by stimulating intercalated cells with hydrogen ion primary active transport pumps. The antidiuretic hormone. Without ADH, the late distal tubule and chordal collecting ducts have little water permeability. Okay, so its effect is to decrease urine volume, antidiuretic hormone. So it's going to decrease urine volume. It's caused by an increase in water retention due to an increase in aquaporins and an increase in water reabsorption. So it will increase the number of aquaporin molecules. HO natriuretic peptide. Remember, HO cells release with the increase in blood volume. Its effect is to increase sodium and water in the urine and the increased natriuresis or excretion of sodium. This will inhibit ADH and aldosterone release, causing less sodium and less water reabsorption. Now finally, let's look at the medullary collecting system. This is the last chance to regulate fluid, electrolyte, and acid-base balance. The medullary collecting system is impermeable to water without antidiuretic hormone. With ADH, however, it reabsorbs large volumes of water. intercalated cells actively secrete hydrogen ions to remove the toxic hydrogen ions and continues to reabsorb sodium and chloride. So let's look at the reabsorption. So these are just figures that I put together from the chapter that you have together to help review the material. Okay. Now, we kind of went over lightly the loop of Henle, and we're going to show in the next lectures how important the important process they are that's going to occur to reduce the water volume and to form a concentrated urine. Okay.